Hello everyone. We have a number of people. Yes, we'll just start. Hello everyone. You're welcome to today's webinar with the good. Just a little bit of the housekeeping rules, the meeting etiquette. For the duration of this webinar, your audio will be muted and your cameras will also be turned off. If you have any questions or comments, you can submit via the chat function or the Q&A button. Our meeting host will share this with the speakers at the end of the webinar. We'll be sharing further information about the GTC Trainee Committee also in the chat function. So your meeting host today, my name is Linda. I'm a dermatology trainee from Nigeria. We also have Fortunate McCoy, Jamila Garib, and Tembiso Malanga, who will be co-hosts with me today. GTC Trainee Committee is part of GLODEM, which is an international alliance for global health dermatology, and also a part of International Foundation for Dermatology. We promote knowledge equity by improving access to education for dermatology trainees across the world, and we aim to provide free educational events and opportunities as well. So introducing our speaker for today, our speaker is Dr. Ibekwe, who is a distinguished dermatologist and senior lecturer at the University of Abuja Teaching Hospital, Bagolada, and Faculty of Clinical Sciences. She graduated in 2001 and completed her dermatology residency in 2010, followed by a transformative year of medical dermatology training and a PhD in medical research at the Ludwig University, Munich, Germany from 2010 to 2014. She holds a prestigious certificate of excellence in allergy and clinical immunology from the European Academy of Allergy and Clinical Immunology. Her expertise spans allergies, dermatitis, infectious skin disease, and pigmentary disorders. Beyond her clinical and research pursuits, she's also the secretary of the Nigerian Association of Dermatologists, and we'll have her as a speaker today. So without further ado, I'm handing over to Dr. Ibekwe to take over from me. Thank you very much.
Thank you, Linda, and welcome everyone to this presentation. I would like to thank the GLODEM committee for giving me worthy to give this presentation. As we all know, contact dermatitis as a topic is quite broad, and so I thought of preparing this lecture as making it look have the following outline. We're going to look at the overview on the classifications of contact dermatitis as well as the management. So going by definition wise, it's an inflammatory response to an exogenous agent, contact an exogenous agent. And the reaction could be acute depending on the cause at which point this contact was made and the inflammation was elicited. So for acute reactions, we have a red or erythematous rash with purples, vesicles, and crust. And if the exposure and the inflammation continues, we can have secondary features of lichenification, fissuring, and as well as scaling. You could say that contact dermatitis has two broad arms. 80% of the time, contact dermatitis is actually non-immunological in nature, and this is what we attribute as irritant or toxic, while the immune component in most cases just 20% of the time. So for the non-immune contact dermatitis, what is actually involved is a direct skin damage, whether there's skin barrier disruption, there's chronic exposure, and the individual is usually susceptible. So like most oftentimes, people that are atopic are prone to irritant contact dermatitis. Unlike the immune-mediated, where you have a prior sensitization, a recognition by the immune system of this allergen, and the reaction is as a result of that recognition and not as a direct response by the keratinocytes. So basically, if you look at this, you see that the for the immune component, we can have this allergen being presented by the antigen presenting cells, like Langerhans cells, to a naive T cell or a naive B cell. And the naive T cell will go ahead and produce effector T cells that are specific to that allergen. For the B cells, they will produce IgEs that are specific to that allergen. And this sort of dictates the kind of reaction that will occur. For the effective T cell, we have the type 4 hypersensitivity reaction occurring. For the allergen and the B cell direction, we have the immediate reaction occurring. For the non-immune arm, so you have skin disruption, you have epidermal cell damage. What is actually at play here is the active innate immunity, the activation of the innate immunity of the body, or the direct degranulation of mast cells. So basically, looking at this schematic diagram of direct or non-immune response, you will see that already there's a disruption of the epidermal barrier, and this allows the allergen to get in to the epidermis, and this causes the keratinocytes to release pro-inflammatory mediators, which are interleukin-1, tumor necrosis factor alpha, and this goes ahead releasing more cytokines, will activate the fibroblasts, will activate endothelial cells, and recruitment of leukocytes, and continue the perpetuation of this inflammation. For the immune mediated, particularly the type 4 mediated, you have the haptin. Haptins are usually smaller than protein. So you could have the chemical as a haptin, complexes with a protein, and forms an active antigen. And this is recognized by the antigen presenting cells. They present it to the T cells, which get sensitized. Memory cells are formed. These memory cells are taken back to this skin location. And on further exposure or re-exposure of this allergen, the T cells remember, and these are the ones that actually release the immune mediators, lead to macrophages and leukocyte activation. So basically, we have 6 different subtypes of contact dermatitis. It's not just allergic contact. We have irritant contact, we have immediate skin reactions, we have photocontact dermatitis, systemic contact dermatitis, and the non-eczematous. Like I said before, the common dermatitis, because it's a dermatitis, it should give you an eczematous reaction. But we do have some cases where the contact dermatitis is actually not eczematous in nature. So going just briefly through the allergic contact dermatitis, this is a type 4 reaction to the allergic, in the allergic individuals, so repeated contact to what has been sensitized. So the allergen had to be sensitized. It has memory T cells in place. Oftentimes it occurs at the contact site, but it could actually go beyond the contact site. Sometimes it could be as a result of probably when someone exports it there, like in hand movements. You have someone with hand dermatitis. The common example is with nail, in acrylate or nail polish. You put a nail polish on the hand, and you can actually put it on the face, and you can have allergic reactions occurring on the face. Most oftentimes, like I said, it's eczematous in nature, and the source of the allergens are quite varied. Almost anything that you can think of can cause allergic reactions, but the common ones that we know are the dyes, cosmetics, medications, plants. So depending on what has been sensitized, but I just want to bring out these special ones. allergic contact dermatitis to food is actually very rare. It's not so common like the dye and the cosmetics. So when it comes to food, we have this Eurosure, which is the agent that has been that is associated with poison ivy and poison oak. So which is found on the skin of most fruits. For example, someone that has this sensitization to this agent eats mango and the mango fruit, we could end up developing perioral dermatitis. Then we know that peroxylone resin is found associated with spices. So I had a patient who was reacting to ginger and garlic, which she normally uses to make a special drink. Then we can have airborne allergic contact dermatitis. This will be to allergens that are airborne that patients can come in contact with. The common one will have to be fragrances or volatile chemicals. Conjugal contact dermatitis is also not rare. So this is like a contact dermatitis due to contact with someone with close body contact. It could be with a spouse, a partner, or even between a mother and a child. So the patient, him or herself, is not having direct contact with such agents. So example would be like body cream or fragrance, for instance. The partner is the person using it. And once, because of that contact, the patient develops contact dermatitis. Moving on to irritant contact, there are two main factors that are involved. This is the most common contact dermatitis that we have available. So there's the intrinsic factor and the extrinsic factor. So the intrinsic factor depends on the age, the sex, the body region. So the age, you know that children are more susceptible to irritant contact dermatitis because their skin barrier is easily compromised, unlike that of an adult. Then females, we expose ourselves more often to irritants than men do. And the body region involved also, know that because of how we work with our hands, you can have more hand dermatitis than you can have on the body. And then the presence of atopy actually increases someone's susceptibility to irritant contact dermatitis. Then the nature of this irritant, if it's acid, you know that acid, alkaline, depending on how strong they are, can cause irritations. The amount also, you can just imagine the duration. So someone that might take a longer time to have a reaction to a mild irritant than to a concentrated irritants. Then there's this synergistic effect that can occur because most often times individuals are exposed to multiple irritants at the same time. So you could have an irritant, two irritants canceling out each other or making the dermatitis worse. So the patient is exposed to an acid and a base at the same time. So this could cancel each other because we could neutralize each other, the chemical process. Sometimes most times the presentation of irritant contact dermatitis is actually multiple, depending on what it is, and then what the factors are. And in most cases, it might be difficult to differentiate the features from that of allergic contact dermatitis. It's in irritant contact dermatitis that you can talk about physical factors like dust, perfume, fragrance, chemicals like detergents, or biological factors like exposure to animal products or plant products. Then sometimes the presentation can be so rapid, like in chemical burns. So within a minutes of exposure, patients have painful erythema, blisters, formation, necrosis, or it could be just an irritant reaction, as mild as an irritant reaction. This can occur from like multiple washing of the hands. You know, it erodes the lipids from the stratum corneum. So washing the hands, you just feel this dryness or scaliness. You have some people that wash with soap and this occurs, or they touch garlic or onions. This discomfort is usually very mild and it's sort of discontinuous, or the patient doesn't feel it anymore once they apply a skin cream. But with persistent exposure, this can progress to an irritation stage. And in this case, it's actually difficult to differentiate that from allergic contact dermatitis. You have diffuse dry erythema desquamation, which is more specific to irritants, unlike allergic contact where you have swelling, you have this with the redness as well in it. And most often times the lesions tend to resolve quite quickly once the irritant is removed. Unlike with allergic contact dermatitis, that it takes a little while, though you have some cases of acute irritant dermatitis where they might take time to resolve. Then another confusion, you could have airborne irritant dermatitis as well, from dust, from steam, and this can also be indistinguishable from allergic contact dermatitis. Then if this exposure goes on for more than 6 weeks, you could have this eczema presenting with dryness, chapped skin, lichenification, and sometimes this can coexist with allergic contact dermatitis. So in such patients, you do a patch test for them. You can have an allergic reaction showing, but when you now come down to finding out the clinical relevance, you're just wondering, is this what is actually causing this dermatitis, or is this something else? And most often times, chronic irritant contact dermatitis is associated with occupation. It makes sense. Somebody's has to earn a living, and so has to subject themselves continuously to this irritant. There are some cases where you have subjective reaction. The patient will tell you once they apply this cream on their face or on their hand, they just had this mild period where they had pain, itching, burning sensation, but there are no lesions to be seen. And of course, it's common in women. So these are like the different forms of irritant contact dermatitis. So this will now come to our first poll. So we want you just to assess whether you have made any points. So can we go ahead, please?
Okay, yes. So the first poll, it says, which of the following is the most distinguishing factor between immune-mediated and non-immune-mediated contact dermatitis? So you can actually try to answer. For A, skin barrier disruption, B, genetic susceptibility, C, prior sensitization, and D, type of allergen. Okay, a few more seconds. All right, I'm ending the poll.
Okay, so thank you for your response. Prior sensitization is definitely the answer, because you don't need prior sensitization for for contact dermatitis to occur. So that's one of the most distinguishing factors. So the same type of allergen can cause irritation, as well as can cause a non-immune as well as an immune contact dermatitis. Like nickel, for instance, can give you an irritative dermatitis as well as an allergic dermatitis. Genetic susceptibility can occur either way, so it's not like a distinguishing feature. And the same as skin barrier. Thank you for sharing the poll. Can we move?
Yes, please, we can move forward.
Okay. All right, so let's go to the other type of contact dermatitis. So we have immediate skin reactions. Examples are the contact urticaria and protein contact dermatitis. Contact urticaria in this case is not the same as chronic urticaria. In fact, contact urticaria is seen as a subtype of physical urticaria. And then usually we have the wheals forming, the flares forming, occurring within 1 hour of skin exposure and clearing within 24 hours. So that's the only similarity between them. And then sometimes you can have a delayed onset, which can be 4 to 6 hours, but still everything resolves within 24 hours. And interestingly, with this type of reaction, we have the immune and the non-immune reaction. So it could be as a direct release of mast cells, or it could be as a form of type 1 hypersensitivity reaction, as I explained earlier. So looking at contact urticaria, this is quite rare. It's not common at all. So you have at the site of contact, patients will develop wheals, flares, and itching, and usually appears within 30 minutes. And like I said, you have the immune, you have the non-immune, and you could have a mixture of the two. And different examples can be found. The most common for the immune contact urticaria, which we can be familiar with, all of us can be familiar with, is with latex gloves in the hospital. So looking at them much more closely, you could see that in this case, we just have a sort of a shift. I said earlier, for allergic contact dermatitis and irritant contact dermatitis, the atopic individuals are more prone to irritant contact dermatitis. But with these immediate skin reactions, you can see that the atopic individuals are more prone to the immune contact urticaria than the non-immune. Then prior sensitization, of course, is required for the immune. Protein has to be there in addition to chemicals. And although the pathogenesis for the non-immune is not clear, for the immune-mediated, the allergens are recognized by the specific IgE, which are bound to IgE receptors on mast cells. And once there are more than one or two bind together, this can lead to the degranulation of the mast cell or the basophil. And what is being released is histamine, prostaglandin, and leukotriene. But you could note that for the non-immune contact urticaria, histamine does not play a factor. All right, and that is why antihistamines are not used in the treatment of non-immune contact urticaria, because they do not play a factor in the mediation. And the reaction could be localized or it could be generalized, almost similar with that of dermatitis. So what is, how do we make diagnosis? We can only use tests for the non-immune, but you could do the prick test and specific IgE test for the immune contact dermatitis. Looking at the immune contact dermatitis, there are actually four types, depending on the organism, the material that is that is provoking this contact urticaria. So it's called type 1 if it's fruits or plant derived. It's 2 if it's animal derived protein that is eliciting this contact urticaria. It's 3 if it's grains, and then 4 if it's enzymes. Let's not also forget that preservatives can also cause contact urticaria, just that they are not within the classification. For protein contact dermatitis, this actually occurs on the hands and forearm after contact with a proteinaceous material. So who are those that are prone to this? These will be the bakers, the chefs, the cooks, the farmers. So immediately they come in contact with this, with the proteinous material that they are dealing with, they suddenly develop these eczematous reactions on the hand and the forearm. And sometimes it's also something to note that when this group of workers present with chronic paronychia, it is something that we need to watch out for. It will be a form of protein contact dermatitis presenting. The pathophysiology is unclear, though some people believe that it's a type 1 hypersensitivity reaction due to the penetration of the proteins through the skin. So the diagnostic criteria is just, there has to be sign that there was a proteinous, there's a contact with the proteinous material, there was a reaction that occurred a few minutes after, and then immediate skin tests are usually positive, while the patch test is oftentimes negative. And once you put this together, you can make a diagnosis of protein contact urticaria. All right, so let's move on to the photocontact dermatitis. So this patient has contact with this material, but that doesn't give the patient any inflammatory reaction, except when there's now an exposure to light. So without light, there's no reaction. With light, there's a reaction. So the radiation could be UVA, UVB, visible light, artificial light, but of course, the most common is the UVA, and it is also divided, like I said, into immune and non-immune. The non-immune is also known as phototoxic, and the immune is the photoallergic contact dermatitis. The mechanism is still the same. Photoallergic requires prior sensitization recognition, while the non-immune is just a direct damage, as the case may be. And for most of them, you have to differentiate with a photo patch test. So the photocontact dermatitis, usually the areas that are exposed to the sun are the areas where the rashes develop. So and it could be so clear as far, there might be a clear line between it. So it could be that the area that was exposed is the, let's say the patient rubbed, using the face for an example, you applied the cosmetic photosensitizing material on the face, and only one side is irradiated. That is the only side that will have a rash. So and you could have a line to show where it is, or it could be that the area that was applied, so you did not apply on one side and did not apply on the other side. So and both sides were now exposed to the sunlight. So it shows a clear line between the exposed and the non-exposed. It's usually might not be symmetrical in nature or evenly distributed. So depending on where the exposed which area is exposed. So like someone that applied all over the face and is a driver, the side where that is facing the sun will likely have dermatitis, unlike the side that is shaded away from the sun. So that will give it an asymmetrical appearance. So for phototoxic, photoallergic, what's the difference? It's almost the same as the allergic contact and irritant contact. So within a few hours of light exposure, you have manifestation, and sometimes it will be as severe as a sunburn. So for those of us in Africa, with type Fitzpatrick skin type 5 and 6, and someone tells you that they are having sunburn, you have to listen more closely, because sometimes it could be as a result of the cosmetic that has been applied with the sun exposure causing them actual sunburn. For the phototoxic, it has to be at first exposure, while for the photoallergic will be after it has been sensitized, so which will take 2 weeks or more, or a month. And then the side that is irradiated for the photoallergic might go beyond that irradiation site, while for the phototoxic, you can heal with pigmentation. In fact, this is why we use Soraline, which is a phototoxic allergy to treat vitiligo, because it usually heals with hyperpigmentation. Just to note that sunscreens, even though we are advocating for it, can actually cause photoallergic contact dermatitis. So we have to watch out for that. And you can see that most often times we picture the allergy just follows the area of application. Phototoxic reactions follow the area of application, as you can see in this picture. The lady was trying to remove the pigmentation around her knuckles and applied a cream she got in the market, and you could see that this actually resulted into more pigmentation. Sometimes you could have systemic contact dermatitis. This is another form of contact dermatitis that results from systemic injection, usually of drugs, but it could be of metals like nickel. So oral administration, intramuscular, intravascular, or even absorption from the skin. And the patients will usually develop eczema at the sites, at the usual sites, even though patients will say they never came in contact with. So you could see someone developing, if someone a lady that has nickel dermatitis, could actually end up and got exposed systemically to nickel. You could actually have rashes around the usual areas like the earlobes or the belt region. Sometimes the reactions could be so bizarre. So like ponfolix, for instance, patients present with ponfolix always think of a possible systemic contact dermatitis. And then there's this syndrome called the baboon syndrome. You can see the baboon picture there. This is because of how they present. Most often times, the patch test is positive. So for the baboon test, I have a patient that presented to us. You could see that the eczema is just around the gluteal region, but I really don't know why they call it the baboon syndrome, because it's not just the gluteal region that you have this eczema. You can actually have it in front as well. You see in this patient, even the umbilical and the flexural regions. And then when we went ahead and did a patch test, don't be confused about this. This is not it, but you could lay your eyes on this area. This is where you had the reaction. And on the day 5, you could still see that this is actually a reaction, and it turned out to be neomycin. And further questioning showed that it was a cross reaction with aminoglycoside, which it took a few days before the rashes erupted. So for the last subtype, that's the non-eczematous contact dermatitis. Sometimes the contact dermatitis will not present as an eczema. It can present as erythema multiforme, lichen planus, and even then can mimic mycosis fungoides. We've had reports of this occurring. So most often times it's a high degree of suspicion that is required. If you suspect that whatever you are looking at is possibly a contact dermatitis, always go for it and do a patch test, and you see it might usually be positive. So we've come to the end of the first session. So these are just a brief recap. We've talked about the 6 different clinical subtypes of contact dermatitis. So how do we approach contact dermatitis? So medical history is so important. You need the history to be able to have an idea of what these patients could be reacting to. Like I said, it's a myriad of things that are out there. Occupation history also helps. You ask about use of barrier, if the patient is using barrier in their occupation, how often the patient is using this, does it improve when the patient is on holiday? Then we need to focus on the distribution as well. So we know that for hand dermatitis, the common things, especially in a hairdresser, it could be dye, it could be the cosmetics, formaldehyde, it could be balsam of Peru. So those are the things that will help shape what the questions you are going to ask this patient. Then it could also help you with the distribution clues. Like this patient now, I'm sure all of you that are looking at it will say this lignified patch below the umbilicus is classical for nickel dermatitis. Okay, but we also do not forget that there will be other you should also consider differential diagnosis. So like I normally tell my residents, you have a hand dermatitis patient. So apart from allergic contact or irritant contact dermatitis, you have to think about atopic hand eczema, you have to think about psoriasis, you have to think about even tinea magnum. So don't forget your differential diagnosis. But going back to the diagnostic clues, you don't dismiss any clues. You have to completely, at least when it comes to examination, know what to do. So this brings us to our second poll. I want you to look at this 50-year-old man that presented with this eczematous lesion and guess the likely allergen.
Okay, the second poll goes with these pictures, and the question goes like this. It says, what is the most likely allergen in this patient? So there's nickel, leather, textile dye, and rubber. All right, few more seconds. Okay, and we're ending it.
All right. Thank you for this poll. I was a little bit mischievous here, but I wanted to bring out that you don't just dismiss, because yes, there's a struggle. Is it nickel? Is it leather? Okay, because you are looking at a eczematous lesion below the umbilicus. So, but you know that this goes to show why we are dermatologists. You don't just look at the area the patient brings. You have to examine the patient as a whole. So by further looking at the patient, you could see this second picture, you could see that this rash is not just below the umbilicus, it actually goes around the waist of the patient. And then this patient also has a lesion, eczematous lesion on the dorsum of the feet. And by the time we did, it was kind of confusing. So by the time we did a patch test, it just happened to be products of leather. So those that said leather are actually correct. But this exercise is also to show you that most of the time, like 20 to less than 20, 30% of the time, what you think this patient is allergic to is not correct. So that's why you need to go further and do further tests. And even for the patients, 60% of the time, the patient is not correct as per this is what I'm allergic to. So using history, yes, history examination is important, but we need to go further to do more.
Thank you, Dr. Ibekwe.
So what are the diagnostic tests that we need to do? Patch test, photo patch test. So depending on what you're looking at. For the immediate type reactions, we have the skin test and the in vitro allergen test, which we're going to just briefly look at. So patch test is a classical, easy, reliable method of detecting contact dermatitis. It helps you, especially when you're not sure, is this irritant, is it allergic? It helps you differentiate the two. Like we just said, the two can present alike. Then whether it's negative or positive is both important. It's not that, I don't want to do this patch test because it's likely I'm not going to get anything. But even if it's negative, it tells its own story, okay? It helps you to explore the role of contact sensitization. Why is this patient not getting better? Why is this rash getting worse? Let's say in a patient you are treating for atopic dermatitis, for instance, you've introduced corticosteroid, topical emollients, is patient reacting to the corticosteroid or the topical emollient? Those are the things to look at. Then patch test gives you the avenue to find substitutes for this patient. So you don't just identify what it is, you can actually give the patient options. All right, so if the patient is reacting to a component, let's say paraben, for instance, in the emollient, you can tell the patient, okay, go for creams that do not have paraben. And in the end, you are still managing your atopic dermatitis with your emollient, and the patient is fine instead of getting worse. Then most often times we have the thin chambers, that's where it's being applied. We have the IQ chambers or the true test system. These ones are already come prepared. But most often times you might need to impute the allergens on these chambers. And how do you select your allergens? Most often times we have the commercial allergens, and they are actually grouped into three. We have the standard, which is recognized by authoritative institutions. So like the European baseline series approved by the European countries, you have the North American, and you have the New Zealand, you have Indian series. So those are like a group of allergens that have been recognized by these institutions to be used. And then we have the screening allergens. So the metal series, fragrance series, depending on what you want, you are fishing out for. The patient that is going for implant, for instance, you want to fish out, is this patient likely to be allergic to this implant? So you can do the metal series. So depending on that. Then the backup allergens are those that ordinarily they don't form part of this. You just feel that because they have low positive rates, but you are suspicious that, oh, this might be it. This patient might be reacting to this, so you add it up. You can't do backup allergens with true test because true test already comes prepared. But with the thin chambers and the IQ chambers, you can do this. You can also self-make your patch, your allergen. So based on your history, you know what is it that this patient could be reacting to. You could use the material as it is. So most often times it's easier when it's a cosmetic, when it's a cream, a lotion, you could just apply that directly. But sometimes you might need to like formulate it. So, but you have to pay attention to the vehicle and then the concentration. The common vehicles that we use are water and petrolatum. You don't use a vehicle that the patient will be allergic to. And then the concentration, most often times, even for lotions or leave-on conditioners, you might need to dilute it a little bit, 1 to 10, just so that you don't elicit an irritative reaction. Then it's always better to avoid patch testing when the patient has acute severe flares, because it can give you false positive reaction results or angry back. So you won't be able to detect or really know what this patient is reacting to. First of all, treat the patient, then you can now go ahead and fish out what is this allergen. Then it's often placed at area of the back that has less, can affect daily activity. So that is why the back is often used. So if you can't, you use the inner arm. Then when you are placing it, don't place it around bony crevices so that it doesn't squeeze up or remove or make the patient uncomfortable. Avoid skin lesions or pigmentations or vascular lesions, because you need to be clear. It needs to be clear to you and even the patient that this is the reaction to this allergen that I have placed on your back. So looking at this picture now, on the body, you need to differentiate if this reaction is an irritant reaction or an allergic reaction, according to the International Committee on Contact Dermatitis. So if there's a bulgeness or redness, so yes, I know that this is a problem for dark-skinned individuals, but it's not that bad, okay? Sometimes we see, most times we actually see, and when you take a picture, you can actually appreciate the redness much, much better than just looking directly. So it's not all lost as it is on dark-skinned individuals. You can see that the reaction usually goes beyond the chamber, as you can see here and here. So that is an indication that, okay, this is an allergic reaction. The reaction is usually papules and vesicles that can group together to form blisters. So obviously itchy. Patient is concerned. This particular spot is actually very itchy. And the reaction lasts over 4 days. In fact, that is why the second reading is usually what is taken. You don't take the first reading because the patch test is placed on the back for a minimum of 2 to 3 days. At that second day or third day, you remove the patch to read. Whatever you see there is not what you should like hold on to. You wait a little, tell the patient to come back day 5, day 6, and then you'll be able to really clarify if this is an allergic reaction. For the irritant reaction, what you see are pustules, necrosis, or wrinkles. I don't know if you can appreciate this here. Okay, so these are what you are occur. And then you see that it takes the shape of the chamber, the shape and the size of the chamber, and the reaction fade quite easily, quickly. So by the time you are doing your second reading, you can hardly see that it's there. So I'm going to show you an example of the patch test. So this is a young boy we did a patch test for. You can see we try to avoid the clavicular region here. Tell them to go home, no sweating. I know it's difficult, but no sweating, no exercises to remove so that the adhesive doesn't remove. So this patient is actually presenting at day 2. So when we removed the patch test, you could see that, okay, there's something here. So, but this is just looking at it from afar. After you've removed it, you wait like 20 to 30 minutes for the angry plaster the reaction to go off. So looking at the first strip, you could see that there's absolutely no reaction that can be seen. But here, you could see this is a stain from the allergen, but you could see this reaction here. I don't know if you can appreciate this reddish hue surrounding this particular rash here. So this is looking promising. So this is the third strip. So on the third strip, this one is a little bit confusing, okay? So you have this rash here that is like following the same size as the strip, single, but at least these are purples. And then you have this one, you have this swelling, and I hope you can appreciate it, that goes beyond the chamber. And then what is going on here? I'm seeing a well demarcation of the chamber. Okay, so how do I grade this? So tell the patient to come back. Day 5, you could see the first strip, there's nothing. The second strip, interesting. You see, this is still there. It's even grown larger than the first reading. Then what is here? You see something coming up here. So why the second reading is so important is that some reactions are delayed. So if patient doesn't come back, you might actually end up missing it. So you have to take note of that. Then let's come back to the third strip that was a little bit confusing. Because see, on this area, that area is completely clear. So it shows that what we saw initially was an irritant reaction, but it's not clear. This I'm going to put as query because I'm not sure it has the same size as my fin chamber, but it's really increased like this one did. So you could put that as query for such a patient. All right, so then going to more examples. So there's this lady that presented with this eczematous lesion on the fourth dozen of her feet, as well as the sole, which are very itchy and quite disruptive to her. So how did we use patch test to make a diagnosis? So when we did the patch test, you could see this redness on number 3, number 13, and number 17. It's quite clear. It's almost causing an angry back around this region. So what is 3, what is 13, what is 17? They were both Taura mix, mercapto mix, and mercaptobenzodiazole. And what does these 3 have in common? They are all components of leather. So we now went back because it's always important to do a patch test. You have to sit down with the patient and to address your reaction, the results of your test. How clinically relevant is this? Because for clinical relevance, is it definite? Is it probable? Is it possible? Or is it past? So those are the 4 ways you can define your clinical relevance. Definitive is when you have done a confirmatory test, so you can challenge the test or a use test. But probable is what we most often times do in clinic. So this patient, there's evidence that this patient has contact with that allergen, even at that present moment. So it's going on. Then the probable, you feel that, okay, there's a possibility that that is a component of something she might have touched. So those are based on your history. So going back to this patient, what did we find out is the cause of this dermatitis? It's her use of rubber props. And this is also an example of how patch tests can help out. The sense that we can now give her an alternative. So you can't be wearing this anymore. Go for your leather shoes instead. So that is how interesting patch test can be. So moving on quickly to the immediate skin reactions. The test that is used, you can't use patch test to get the result for contact urticaria and protein contact dermatitis. What we do is the scratch test, the prick test, close scratch test. For scratch test, you scratch the skin, then apply your allergens, and then clean off after 30 minutes. For the prick test, you first of all put the allergens before you prick, and then the close scratch test, for volatile substances that might likely evaporate, so you cover it up. Most often times it's very easy to operate. It's sensitive, but it has a drawback. If a patient is on antihistamines, it has to be discontinued, or very large oral steroids. Or a patient is on theophylline, that has to stop. But remember that antihistamines doesn't play a role in the non-immune contact urticaria. Most often times we use standardized allergens, but there is also room to make up yours. But before you can actually say this is okay, it has to be tested on at least 50 atopic patients too, so that you can rule out false positive reactions. And this is what normally happens when you do this. And for photo patch test, you prepare the allergens in duplicate. Okay, so you apply them on the back of the patient. After day 1 on application on the back, you remove one of these sets and expose it to light. The common test light that is used for this test is UVA, but it's been we've now noticed that UVB2 can cause photosensitization. This is the pack is irradiated for 30 minutes on the 2nd day, and then you do your first reading on the 3rd day, and then your final reading on day 5. For patients that have contact urticaria or protein contact dermatitis that have extensive lesions, they have severe allergic reactions, they are antihistamines, you can not stop them. So this is where you do the in vitro allergen test. You take the blood and measure. What you're measuring for has to be the antigen-specific IgE, because the total IgE is not specific and it does not differentiate between allergens and non-allergens. It's affected by so many things: age, race, sex, and even the presence of parasites. Sometimes the patient can be exposed to a material and we don't have an idea of the ingredients or what is in this material. So these are the quantitative tests that you use to be able to find out what is the components, what are the ingredients in this, the chromatographies and spectroscopy. Be able to break down the ingredients of this, and then you can now go ahead and patch test or prick test, depending as the case may be. The challenge test is, like I said before, is a way of you finding out definitively that this patient is allergic to this. So you could either do it by using the use test, you expose the patient to it, the usual site of the rash, and if the patient develops the rash, that is a confirmation. Or for something that is quite irritative, you can repeatedly apply it on the forearm and see if the patient will develop the rash. But most often times it's done under close supervision, especially in those that have to type 1 hypersensitivity reaction, because it can end up producing anaphylaxis in such patients. So management-wise, conclusively, the solution to contact dermatitis is to know what the allergen or the irritant is, and remove it. That is actually the cure for it. All right, so apply appropriate treatment. So, like, we know that skin barrier is one of the things that predispose patients to irritant contact dermatitis. So maintenance of that skin barrier is important. And I just want you to know that recovering the skin barrier does not mean that the appearance will look the same or normal back to what it was before. It's just to have the physiological function restored, just like in atopic patients. And removing the allergens most often times, especially when it's irritant contact dermatitis, you resolve this reaction. And it can be as simple as rinsing it with water within 10 to 15 minutes of exposure. And this can be quite effective. You could use soap and alkaline to remove activated carbon, and then you could also try to remove a strong alkaline with a weak base or a strong acid with a weak base. So depending, most often times once these have been taken care of, you treat the dermatitis either with corticosteroid or cortical tacrolimus, physical protection when necessary. Like in patients with photoallergic contact dermatitis, you don't know if they're allergic to sunscreens. You can actually tell them to use protective covering. Then the other things that we use. Okay, so this brings us to our third poll.
All right, our third and last poll says, which of these clinical subtypes of contact dermatitis has a negative patch test result? So protein contact dermatitis for A, B, photoallergic contact dermatitis, C, systemic contact dermatitis, and D, allergic contact dermatitis. All right, few more seconds. And
All right, so the answer is protein contact dermatitis. Remember that it is one of the differential diagnostic criteria for making protein contact dermatitis. Thank you for participating. So this has brought me to the end of my lecture. I used Lee's outline to prepare my presentation. I also want to thank Professor Rishishka and the Allergy Clinic of LMO for introducing me to allergy. And then this textbook is what I was my guide at the beginning of my career. Thank you. I'll take any questions that may arise. Thank you very much.
Thank you so much, Dr.
Thank you
Ibekwe.
very much.
Yes, thank you so much, Dr. Ibekwe, for such an informative presentation. It took us from the basic sciences for us to understand, and now with the application of the knowledge. Yeah, just a few questions that we have. Sorry, Linda, about that. So the first question is from Dr. Jonathan Dacker, who asked, how do we manage a non-eczematous dermatitis secondary to hydrochloroquine?
To what?
To hydrochloroquine.
Okay.
Yeah. Okay, so that's the first one. And the second one, it was actually by Dr. Linda, who said that, thank you for this enlightening presentation. How often have you been able to identify the allergens with Pomfolix? So that's the second one. I don't know if you want to respond to the two questions. Yeah, so that they are not as many.
Okay, so to manage them for hydroquinone, I think it's the same way is it hydroquinone or hydroxychloroquine?
Hydrochloroquine, yeah.
Okay, so hydrochloroquine, we know that we use hydrochloroquine for hydroxychloroquine for photo diseases like lupus and SLE. But just like with every allergen, it's actually avoidance, finding substitutes. If the patient is reacting to this, you just have to discontinue it and find another alternative to use. This is usually how you will manage these cases. Concerning the Pomfolix, I must admit that I've had to do patch tests in a few patients, and most often times I really didn't get a positive reaction to it. Looking back, I think I probably didn't think about systemic injection, systemic allergens, because what I used was the ones for exogenous. So probably if I had asked the patient more on the drugs they are taking, I would have gotten a better response. Yes.
All right. No, thank you so much. Yeah, I see there, due to our time, I won't take other questions, but maybe just two questions that we can take is that, what are the common causes of contact dermatitis that you've noticed in your practice? And the last one is, for the recalcitrant contact dermatitis, what other immunosuppressants have you used if your first line of treatment doesn't work? Thank you so much.
Okay, so let me start with the last part. If the first line is usually corticosteroids, if that doesn't work, I move over to methotrexate. Actually, I don't do cyclosporin as the case may be. Then sometimes, especially if it's not due to a photoallergic reaction, using phototherapy has worked in one case of mine. For the common cause of allergens I've come across in my practice, is actually so there are so many. I can't say this is one. Most I've seen to rubber, I've seen to metals like nickel, then what I see more is actually an irritant reaction to methyl glutarate nitrate, which is one of the preservatives we have in creams. I've seen to formaldehyde, that's also very common, and very bizarre ones too. I've had a patient that a retired judge that had periorbital dermatitis, and when we did the patch test, what he was sensitive to was formaldehyde, which happens to be what he was using to clean his glasses, his eyeglasses. I was just wondering why his hands were free, but not the eyes. So that you could have very interesting cases occurring. Saying this is it, I can't really put my finger on it because each case is an interesting case on its own.
Okay, all right. No, I thank you so much, Dr. Ibekwe. I'll hand over to Linda as well, due to the interest of time. There were other questions as well, but due to interest of time, we might not be able to get to them. Yeah. Over to you, Linda.
Thank you so much, Dr. Ibekwe, for the enlightening presentation. I don't know if you can hear me.
Yes, I can.
So thank you all for joining us. Thank you all for joining us for today's presentation. So you can see our recorded version of this presentation on our YouTube channel, and you can follow up on other activities on social media, Instagram, Twitter, Facebook, and even LinkedIn. So you can follow us and see our recorded versions. Thank you very much for attending. Let's all have a thank you. Hello, everyone. Can you hear me?
Yes, we can.
Okay. I'm
Yes,
sorry.
we can.
My net has been. Thank you. So, is Dr. Ibekwe still with us?
Yes, I am.
Yes, Dr. Ibekwe, she's still here.
Okay. Thank you very much, Ma, for.
Yeah.
Thank you so much for honoring our invitation. Thank you.
Thank you very much.
Thank you.
Yeah, thank you.
Hi,
Thank you
Becca.
so much. Yeah. Thanks,
All right,
Linda.
thank you. Bye.
Thanks,
Yes.
everyone.
Yeah,
Thank you.